Today we are presenting live from the AHC Oral Surgery course where we have oral maxillofacial surgeon extraordinaire, Dr Anthony Lynham. Welcome.
Thanks, Jeff. It's great to be here.
It sure is. We've already covered a lot this morning with regards to peritomes and their uses. And Dr. Anthony, this morning you shared with us a very common, unfortunately, clinical scenario with regards to a typical emergency patient who turns up and they have a forceps that's really painful, and you start to take it out and you keep on picking away and it is not going anywhere. So what are your tips for getting that out?
Well, Jeff, we've all had this scenario, and I know a lot of dental practitioners have had this scenario themselves. 4'6", 55-year-old male that's endodontically treated. You know it's going to be tough. The crown breaks off. You're there with your Warwick James. You pick up the cryers. You pick up the couplins. You pick up the luxator. You pick up the periotome. You try to find that instrument you went to the last course about in a drawer somewhere. The nurse is running over the place. You look at the patient. You calm them down. You say, no, things are fine. Things are fine. But in reality, in their own mind, it's a disaster. The sweat's starting to drip and you don't know what to do. And this is the advantage of going to courses such as this, because we will give you the skill and the tips and tricks to avoid that situation. And firstly, don't get yourself in that situation. Learn to identify which teeth are just really too hard and do require referral. And that early on is very important. And that's one of the big things about this course. We show people which ones are difficult, which ones should be referred. We also show people how to get out of that predicament as well. If you are stuck, we'll show a logical sequence in order to remove that tooth safely within the skills of a general practitioner. And what we do build on this course and other courses such as this is we build a muscle memory that people learn. They do repetitive exercises, plastic models on cadavers. They learn how it's done and the techniques and get that memory together so they can extract elements of the erupted dentition. Sometimes it's tough, but with courses such as this, looking at how to select a case and how to deal with a problem like that, it gives increased confidence, gets people out of trouble. But one should always remember, the oral and maxillofacial surgery community are a very friendly community. So if you do get yourself in stride, sometimes you do have to pick up the phone.
Great advice. The second clinical scenario is how to numb up the hot pulp.
Oh, always very difficult. We're lucky as a group in that we always have recourse to a general anaesthetic theatre. I know in the dental community it's very difficult to access general anaesthetic unless you're in regional areas. But what I suggest is a sequential approach. A localised infective area is very difficult. Utilisation of blocks is very important. And there are various block techniques. Everyone knows the mandibular block, but there's various maxillary blocks that people can use really safely that we can demonstrate as well. We do demonstrate on courses such as this on where these blocks are given safely. But also a sequential anaesthesia as well, like the topical, then a submucosal injection, and then when everything's quite numb, then come with the block injection. I think the biggest mistake people make with any local anaesthesia for anything is they forget about the duration of action or the duration of onset of the local anaesthetic agent, and they go too quick. And when you've got to wait, you know, the minimum of 4 minutes, longer, it's hard after you've given the injection to make small talk.
It is.
For 4
Sure
to 10
is.
minutes, and people act too soon. And once your patient identifies that that forcep or that elevator is pain, no matter how numb it is, when you come at them again with that forced spinella, that patient's going to say, this is pain coming. And it's very difficult for you to alleviate that. So the idea is to wait to duration of onset. I personally leave my patient with my nurse so they're in a safe, secure environment, and then I'll go have a cup of tea, do some paperwork, come back after about 10 minutes to make sure it's completely numb before I even start operating.
That's a great tip, wonderful tip, and I think it will certainly help a lot of clinicians at work by just remembering you can't pick up your forceps, your elevators, or your luxators before the tooth is numb. So just give it some time to work. So thank you so much for Clinician's Corner this morning, and we'll see you guys again next time.
Thanks, Jeff. Thanks all.